All right, everybody, this is going to be Chapter 17 of our Emergency Medical Responder course, Pediatric Emergencies. When dealing with pediatrics, with kids, it's important to remember that these are going to be some of the most stressful types of patient encounters that we have. One, it's a little person who is sick. They don't know what's going on. They don't know why this is happening to them. And with adults, it's a little bit easier to deal with them because, one, these adults have probably put themselves in this situation. Not always, but a lot of times, when you're dealing with the 60-year-old patient who has smoked for 40 years of their lives, they now have COPD, emphysema, all that good stuff, and they can't breathe. It's because they've done something to themselves. Or we're dealing with the drunk driver who crashed into a tree and now we're having to deal with them. Those patients are a little bit easier to deal with because they've put themselves in that situation. With the children, they usually haven't done it. Sometimes you'll get the ones where, they were climbing a tree and they fell out. Yes, they did that to themselves. Should somebody have probably been watching them? Probably. But with the ones that get sick or have been injured in some way, they usually didn't do this to themselves. So these are very high stress situations, and we need to learn to deal with that. So, in our introduction, sudden illness and medical emergencies, they are common in children and infants. There are some anatomical differences that exist between adults and children. Respiratory care for children is extremely important. I believe we talked about this earlier in the course, where the leading cause of cardiac arrest in children generally stems from respiratory arrest in children. So something happened to their respiratory function, caused them to go into respiratory arrest, which caused cardiac arrest. All right. So like I said at the beginning, these can be some of the most stressful situations we're going to face as an emergency medical responder. We need to remain calm and professional. We're the ones that are there to help, and that's what both the parents and the children are expecting. Parents add another bit of stress to these calls because, like I said, they want you to do something for their little one. So unless you're prepared for these calls, your anxiety and fear may interfere with your ability to deliver proper care. And the child that you're there to take care of and their parents will know that you're having issues. So you have to be ready for these things. So the parents of the children can be either allies or a potential problem. We need to talk to both the parents and the child as much as possible. We want to develop a rapport with the child. Don't stand over them. We want to squat, kneel, sit down, establish eye contact. Ask simple questions about the pain. With the parents, remember that they're going to be concerned about the child's condition, especially if they don't understand what's going on. And a lot of times, parents will think that the issue that is going on with their child, they might think it's more serious than what it actually is. You have a first time parents with their brand new baby who's running a fever. Is this a medical emergency? Probably. The way they're acting might be a little bit, they might be acting like this is the end of the world for the and to a certain point it is for them. So we need to remember that. So like we said about the parents being allies or potential problem, involve the parents as much as you can. If it's possible when transporting, have the parent ride along with the child. Separating the parent and the child is a good way to cause anxiety in that child. So we want to try and keep at least a parent with them. Let them sit in their lap if possible. try and make it as comfortable for the family as possible. When we're dealing with the children, we need to be honest with the child. Some agencies might have teddy bears, stuffed animals, stuff like that you can bring into the scene with you, so that to help calm the child. So there, like I said earlier, there's some differences between children and adults. A child's airway is much smaller in relation to the rest of the body compared to an adult's airway, and the child's tongue is proportionally larger than an adult's. So with that smaller airway, secretions or swelling from illness or trauma can more easily block the patient's airway. And because that tongue is larger, the child's tongue can more easily block the airway as well if that child becomes unresponsive. A child's airway is also more flexible than an adult's. So when we're doing our head tilt chin lift, or we're opening that airway, if we hyperextend that neck too much, there is a chance that we can close off that airway. So what we were doing trying to help open the airway has actually caused it to be worse. So we need to adjust it just right. We don't want to hyperextend or overextend that neck. We just want to get them into a neutral or slight sniffing position, but don't hyperextend it. So here we go, where just talked about upper airway, more flexible than that of adult. For at least the first 6 months of their lives, infants can only breathe through their noses. So if they get sick, they get a cold, they get all stuffed up, they have a hard time breathing. We need to keep an eye out on that. When the demands on a child's respiratory system change, the child is able to quickly compensate by increasing breathing efforts. Children are very good at compensating for stuff that's going on with them. So when we're assessing them, they can be compensating very well, but then they're going to go over that edge and stop compensating and start having problems very quickly. So it's important that we address what's going on with the child as soon as possible. All right. So children have a greater surface area relative to the mass of their body than adults. This means that they lose heat faster than adults, and then they have limited abilities to compensate for those changes because of that larger surface area. So just like our adult assessments, we're going to use the following 5 steps, same as an adult. We're going to do that scene size up. We're going to do the primary assessment, secondary assessment, obtain a medical history, and then perform any reassessments as necessary. In addition to our regular assessment, we also have what's called the pediatric assessment triangle. This is going to help us form a quick general impression of the child just by looking and listening to what's going on. It can be used to assess a child from the distance. And as you can see, just like a triangle, it consists of 3 parts. We have appearance, work of breathing, and circulation in the skin. So what does the child look like? How hard are they working to breathe? And what does their skin look like? Are they pale? Are they flushed? Do they have a normal color? So with appearance, it's an indicator of how well heart, lungs, and central nervous system are working. We want to compare the child's appearance to what you would expect from a healthy child. We're going to assess eye contact. Will they look at us? And some children won't look at you. Some children are very shy. Some of them are very outgoing, and they'll talk to you and make eye contact with you. But some of them won't. We also need to look at the muscle tone and their skin color. We need to reassess this regularly because the appearance can change very quickly. Like I said, they'll compensate very well for a long time, and then they stop compensating. Here's some characteristics of appearance. Movement, healthy reactions are moving vigorously. Unhealthy, obviously, is limp, listless, or flaccid. Interaction. If parent hands them a toy, do they reach for the toy? Do they react to their caregivers? Or are they uninterested in it? Reassurance. They're reassured by the caregivers. When the caregivers start talking to them, they can kind of help calm them down. Or when the caregiver tries to reassure them, do they start crying, get more agitated? Are they unrelieved by these reassurances? Eye movement. This is one that you can really use because they will watch you when you walk in the room. All right, whether they're scared or not, they will be watching you as you move about the room. So this is a good one to use. When you try and make eye contact with them, some of them might not make eye contact with you, but they generally will watch you as you come in. So are they moving and following you, or do they just have a glassy-eyed stare and they're not doing anything? Speech. Is it age appropriate, or is it garbled, confused? And cry. Is it good, strong cry? If they're crying, is it good and strong, or is it weak or high-pitched? Remember, these are all good. These healthy reactions are what you would expect from what we're looking for in a child of that age. All right. So our second element is going to be work of breathing. We can determine the child's work of breathing by measuring 4 factors. We have abnormal breath sounds, abnormal positioning, retractions, and flaring. So these are going to be a better indicator of the child's condition than just checking the respiratory rate, rhythm, and quality. Okay, like I said, we determine it measuring these 4 factors. Abnormal breath sounds. Is it noisy? Do we hear snoring, crowing, grunting, wheezing? Any of those are abnormal. We need to note that. Positioning. We talked about tripod position before. It's just leaning forward, using their arms to support them. That's the tripod positioning. It's abnormal. Retractions. So we talked about them before, but you'll see them in the clavicles or between the ribs. And then flaring of nostrils. When they inhale, do their nostrils get huge? That's flaring of nostrils. These are all abnormal, and we need to keep an eye out for them. All right. Last one is going to be circulation of the skin. So we use 3 different characteristics for this one. We have paleness, mottling, and cyanosis. So we're going to check the patient's skin for any paleness or pallor. White or pale skin indicates inadequate blood flow to the skin. Second condition to the skin is mottling, and this is a patchy skin discoloration caused by too much or too little blood flow in the skin. So you'll see it looks just like patches on their skin, exactly like what it says here. You should be able to tell. You'll know it when you see it. Cyanosis, we've talked about this before. This is blue discoloration of the skin and mucous membranes. When we do check our respirations, we want to count respirations for 30 seconds and multiply by 2. On these ones, remember when we talked about adults, we could do it by counting for 15 seconds and multiplying by 4. With children sometimes do have irregular breathing patterns, so we want to do a full 30 seconds and then multiply by 2. And then if you have any doubts, go ahead and count it for a full minute. All right. We need to look for signs of respiratory distress. It says how much work the child is doing to breathe. And then we need to listen for abnormal breath sounds, such as noisy breathing, snoring, crowing, grunting, wheezing. Remember, we're also looking for them in that tripod position and the retractions. That's where the skin is sinking in, especially above the collarbones or between the ribs. So, like I just said, we're looking for that tripod position, retractions of the neck and chest, and then the flaring of the nostrils. So once again, just like we talked about in work of breathing of the pediatric assessment triangle, these are the things we're looking for. Apparently, if we keep talking about it, it's got to be pretty important. So the normal pulse rate for a child is going to be faster than an adult's normal rate. In a child younger than 1 year, we want to palpate the brachial pulse, which is located there between the shoulder, halfway between the shoulder and elbow on the inside of the upper arm. All right. So here we can see what should be normal heart rate and respirations for the different age groups: newborns, infants, toddlers, preschoolers, school age, and adolescents. Okay. High body temperature. So high temperatures are usually accompanied by flushed red skin, sweating, restlessness. To feel a high temperature, with the back of your hand, touch child's chest and head. It's important to remember that a child's heart rate will increase with each degree of temperature rise. Okay? So, respiratory care. Once again, it is very important to keep an eye on these little guys with their airways and respirations. Problems with respiratory, like I said earlier, we start having problems with our respiratory drive. They start diminishing. It eventually ends up being respiratory failure, which turns into cardiac failure. So we need to keep an eye on these little guys. That's the biggest reason for cardiac arrest in children. Like I just said, so causes of cardiopulmonary arrest in children: suffocation caused by aspiration of a foreign body, infections of the airway such as croup and epiglottitis, SIDS, accidental poisonings, and injuries around the head and neck. So notice that these first two are big airway and breathing issues. So we need to be taking care of them. All right, so when we're treating these respiratory emergencies, we need to get that airway open. We want to use the head tilt chin lift maneuver on children who have not sustained an injury to the head or neck. We do not want to hyperextend the neck when you tilt that head back. So remember that their airways are very flexible. If their head's too far forward, the airway will be closed off. If it's too far back, it'll be closed off. We want to get them in a nice sniffing position to open that airway. If there is any possibility of injury to the head or neck, we're going to try the jaw thrust maneuver. With basic life support, if we have to start CPR, it's going to be a little bit different than adult CPR. If we're alone and emergency services has not been called, we want to do 5 cycles or 2 minutes of CPR before activating that EMS system. So before we call for 911 with children, we want to do about 5 cycles of CPR first. Then we're going to use when we are doing CPR, we're going to use the heel of one hand or 2 hands to perform the chest compressions. We want to compress the sternum to at least 1/3 the depth of the chest. Remember, we don't need to touch the patient's backbone. We just 1/3 of the depth of the chest. Nice good compressions. And then our CPR for infants is going to be different from adult CPR as well. We're checking for responsiveness by tapping the infant's foot, gently shaking the shoulder. We're checking that brachial pulse. We're going to use the middle and ring fingers to compress the sternum just below the nipple line. Compress it to at least 1/3 the depth of the chest. And then we're giving little tiny, gentle rescue breaths. Adults, we can give them that full breath. We're still just looking for that chest rise on adults. Same with children. When we give them a breath, we're just looking for that chest rise. And then the little babies, just looking for that little bit of chest rise. These are going to be little tiny breaths. They have little tiny lungs. Okay? When we give those rescue breaths, we can use, if we're doing mouth to mouth with the infants, it would be mouth to mouth and nose ventilations. Okay? If we need to suction an airway, We're going to turn the child on his or her side, use a gloved finger to scoop out whatever's in there. Use suctioning to remove the rest of the foreign substance. Remember that suctioning can be a life-saving procedure. All right, so the procedure for suctioning is the same for adults with the following exceptions. We're going to use that tonsil tip or rigid tip to suction the mouth, flexible catheter to suction the nose of a child. Might use a bulb syringe. If you have babies, you know what this is. It's that blue bulb. You squeeze it, it suctions their nose out. You never want to suction for more than 5 seconds, because if you're suctioning, any air that they're getting down in there, you're sucking back out, so they're not breathing. After doing some suctioning, we need to try and ventilate and reoxygenate the patient before attempting to suction again. Remember, when we are doing our rigid type suction, we're inserting that suction no further than we can see. Don't go getting down into their esophagus or trachea. If you can't, you're only going down as far as you can see. Airway adjuncts. So oral airways can maintain an open airway after we've opened that patient's airway manually. There's a step skill drill in your book, 17-1. The one thing on this is that it's almost the same as inserting for a adult, but we're going to put it in where an adult, we put it in upside down and then turn it. On the child, we're going to attempt to depress the patient's tongue with 2 or 3 tongue depressors, and press the tongue forward and away from the roof of the mouth, and then we'll follow the atomic curve of the roof of the mouth, putting that adjunct in. Okay, with children, you don't have to turn it because you're going to attempt to get the tongue out of the way while you're inserting. Okay, so mild or partial airway obstructions. We're going to place the patient on his or her back, tilt the head, and lift the chin in the usual manner. Remove the object if it is clearly visible in the mouth and can be removed easily. Do not attempt to remove the object if you can't see it or they still have the ability to breathe. Okay, we don't want to force that further down in there. Children need to be transported to emergency department so they can get that out. So remember that children have a tendency to put everything that they touch into their mouth. These can be toys, candy, stuff they find lying around. Once again, if it's only partially blocking the airway and is still able to pass air, we don't want to try and remove it because we might make it worse. If you can see it and you think you can easily get it, you can attempt to, but just remember that there's that possibility of pushing it further back down there. So as long as they're moving air past whatever it is, it's usually best just to leave it in place. So if you have oxygen, go ahead and administer it, and if you're trained to use it, we're going to place that oxygen mask over the child's mouth and nose. We don't have to get an airtight seal. Might hold it about 1 or 2 inches away from the child's face just to get a blow-by, just give some extra oxygen. So severe or complete airway obstructions, this is a serious emergency. This is when when an obstruction exists, a severe airway obstruction exists when the child has poor air exchange. So before they were getting some air past whatever it was, now they're getting almost nothing. They're going to have increased difficulty breathing, a silent cough, inability to speak, no air movement because of the obstruction. If this is the case, we're going to use the Heimlich maneuver to try and get that whatever out. Should provide enough energy to expel most foreign objects. Steps for doing this: on a conscious child, 1 year to the onset of puberty, are the same as for an adult, but you might have to make a couple little adjustments. When we're opening that airway, we're tilting the head back just past that neutral position, trying to get a straight shot out of there. If you were by yourself and the patient becomes unresponsive, once again, we need to perform CPR for 5 cycles before activating that EMS system. Okay. So with a complete or severe airway obstruction in infants, we need to remember that an infant is very fragile. They are easily breakable. If we suspect an airway obstruction, we need to assist the infant determine whether any air exchanges move is occurring or not. If the infant is crying, the airway is not completely obstructed. No air is moving in and out of the infant's mouth and nose, we're going to suspect an obstructed airway. If that's the case, we're going to use a combination of back slaps and chest thrusts to get this out. So like I said, we're going to assess the infant's airway and breathing. Place the infant in a face-down position over your one arm. Deliver 5 back slaps between the shoulder blades. And then we're going to flip him over to our other arm, and we're going to do chest thrusts. 5 chest thrusts to the middle of the sternum with your 2 fingers. We're going to repeat these steps until the object is expelled or the infant becomes unresponsive. If the infant becomes unresponsive, we're going to continue by ensuring the EMS has been activated, begin CPR, starting with chest compressions, and continue CPR until personnel with more advanced EMS skills arrive. So swallowed objects, if small round objects do not become airway obstructions, they usually pass uneventfully through the child. Sharp or straight objects can be dangerous if swallowed, and we need to arrange for prompt transport. So those small objects, small round objects like marbles, beads, coins, buttons, stuff like that, they usually get swallowed and passed by the child. With those sharp or straight objects, we need to get them transported because there's a possibility of airway perforation, abdominal perforation, stuff like that. So we need to get them transported so they can get taken care of. Respiratory distress. So signs of respiratory distress is a breathing rate of more than 60 breaths per minute in infants, a breathing rate of more than 30 to 40 breaths per minute in children, that nasal flaring on each breath, once again retractions of the skin between the ribs and around the neck muscles, and stridor. Remember, stridor is a high-pitched sound that happens on inhalation. Also going to see cyanosis, altered mental status, combativeness, or restlessness. Our treatment for respiratory distress is to try to determine the cause. We want to support the child's respirations by placing the child in a comfortable position. This is usually going to be sitting. We're going to try and keep that child as calm as possible. We're going to let the parent hold them if we can. Be prepared to administer oxygen if we're trained to use it. We want to monitor the child's vital signs and arrange for prompt transport. So, respiratory failure and arrest. This often results as respiratory distress proceeds, usually leads into respiratory failure. Signs and symptoms are going to be a breathing rate of fewer than 20 breaths for an infant, fewer than 10 in a child. Muscle tone, so they're flaccid, they're not able to hold themselves up. Unresponsiveness, we got the decreased or absent heart rate, weak absent distal pulses. Remember that these children in respiratory failure are on the verge of experiencing respiratory and cardiac arrest. We have to get them taken care of. So our treatment for respiratory failure and arrest is going to be support respirations by performing mouth-to-mask ventilations, administer oxygen if we have it, begin chest compressions if the heart rate is absent or less than 60 beats a minute. Then we need to arrange for that prompt transport. The important one to remember here is that if that heart rate is absent or less than 60, we need to start CPR. Okay. especially if there's signs of cyanosis or other poor circulation. We need to get that CPR started. Circulatory failure. So the most common cause of circulatory failure in children is respiratory failure, just like we talked about a couple times already. It can lead to cardiac arrest, indicated by the increased heart rate, pale or bluish skin, and changes in mental status. So if the heart rate is more than 60 beats a minute, we need to complete the patient assessment sequence, support ventilations, administer oxygen, observe vital signs. Once again, if it's less than 60, we need to begin chest compressions and rescue breathing. All right, so at times, children can also get altered mental status. These might be due to low blood sugar, poisoning, post-seizure states, infections, head trauma, decreased oxygen levels. Remember that in many situations, we might not be able to determine the cause of altered mental status, and we just need to treat the patient's symptoms. We're going to complete the patient assessment, pay particular attention to the patient's initial vital signs, calm the patient and the patient's family, be ready to support the patient's ABCs, and we're going to place those unconscious patients in the recovery position. Respiratory illnesses. So because we talked about this earlier, because infants breathe primarily through their nose, even a minor cold can cause breathing difficulties. They get stuffed up, they can't breathe through their mouth, they start having respiratory problems. Another respiratory illness you might see is asthma. This is caused by a spasm or constriction and inflammation of the smaller airways in the lungs. Probably going to hear a wheezing sound that goes along with it. We need to calm and reassure the parents of the child. Asthma can occur in children older than 1 year. It rarely occurs during the first year of life. We need to be keeping an eye out on this. Once again, our primary treatment is going to be calming that patient and ensuring both the patient's parents and the child. Tell them we're doing everything we can. We want to place the child in a sitting position. This pursed lip breathing can help relieve some of the internal lung pressure, so that with the asthma, they're having problems getting the air out, not so much getting it in, but they're having problems with their exhalation. So we need to try this pursed lip breathing because it can help relieve some of that lung pressure. If the child is known to have asthma, they might have medication for it. We can help administer that. We need to arrange prompt transport. So our next one is going to be croup. This is an infection of the upper airway that occurs mainly in children between 6 months and 6 years. Results in a hoarse whooping noise during inhalation and a seal-like barking cough. Often occurs in colder climates. It can also present itself later at night. So when the air cools down, you might get calls for a child having respiratory problems. When we hear that seal-like barking cough and it's cooler outside, it's good indication it might be croup. A lack of fright and the willingness to lie down are important signs that distinguish croup from epiglottitis. So patients with croup, they're willing to lie down. They're not as frightened by what's going on. If EMS unit is delayed, a good trick is to turn on the hot water in the shower, get the child in there, and close the bathroom door. Help get some hot humidified air in there. That moist air is going to help relax the vocal cords. Epiglottitis, this is a severe inflammation of the epiglottis. That flap is going to be so inflamed and swollen that air movement into the trachea is completely blocked. Usually happens in children between ages 3 and 6 years. Some of the signs and symptoms, so like we talked about with croup, where patients with croup are willing to lay down. Epiglottitis, these children are usually sitting upright, don't want to lay down. They cannot swallow. There's no coughing. The child is drooling. This is a big one. So like the seal-like cough and occurring at night was with croup. The drooling is more a sign of epiglottitis. The child will be anxious and frightened, and their chin is thrust forward. Remember, if we do suspect epiglottitis, we do not want to attempt an examination of the child's throat. Doing an examination can cause even more swelling of the epiglottis, which can completely block the airway. So we want to make the child as comfortable as possible with as little handling as possible. Keep everyone calm, child, parents, everybody on scene. Administer oxygen and arrange for that prompt transport. So drownings, these are caused by submersion in water. Initially causes respiratory arrest, which leads to cardiac arrest, as we know. Second most common cause of accidental death among children 5 years of age or younger. If you are called to a scene, do not put yourself in danger to attempt a rescue. If you get stuck, if something happens to you, who's going to rescue you? Okay? So do your best, make your best decisions, do what you have to do. All right? Some signs and symptoms include an obvious lack of breathing and no pulse. Treatments are going to be assess the ABCs, turn the child onto one side, allow water to drain from the child's mouth, use suction if necessary, start rescue breathing if necessary. We want to administer supplemental oxygen if it's available. If no pulse is present, we need to start chest compressions. We need to stabilize the neck because some of these drownings are caused by children diving into shallow water, so there could be a neck injury. We want to reduce the risk of hypothermia by drying the child, cover him with dry blankets, and arrange for prompt transport. Something we don't want to do that we've seen in the movies is abdominal thrust. We don't need to try and pump the water out of the patient's stomach. Okay? We treated everything by turning them on their side, address their ABCs, suctioned as necessary. We're not doing abdominal thrusts on drowning patients. We also don't need to pump their legs like a water pump, like you might have seen in the old movies. Okay? With drowning victims, it is important that they are transported to be seen by a physician, because some patients who have experienced submersion might respond, might wake up, might hack out all the water, whatever. There is the possibility of serious respiratory conditions developing hours after that submersion. So you need to get these patients transported to be seen by a doctor. All right, heat-related illnesses. Heat stroke is serious and potentially fatal condition, requires rapid treatment. We want to remove the child's clothing, maintaining their modesty. We want to sponge water over the child, fan him or her. We may wrap them in wet sheets to speed up the evaporation and cooling process. We do not want to let the child become chilled. We don't want to get them so cold that they're now chilled. All right. Then we need to arrange for rapid transport. High fevers. So if any of you have children, you know that fevers are common in children. Because of temperature regulating mechanism among young children, it hasn't fully developed. A very high temperature can occur quickly. Most children cannot tolerate temperatures as high as 104 degrees, which can be possible even with minor infections. So those, even if it's just a little infection that they have, they can spike a fever very quickly. Got to keep an eye on them. Treatment for these is going to be uncover the child so body heat can escape, attempt to reduce the high temperature by undressing the child, maintaining their modesty, fan the child to cool him or her down, and then we want to protect the child during any seizure. So with a high fever, there is the possibility of them having what's called a febrile seizure. We need to protect the child, make sure that they don't injure themselves, and then make sure that normal breathing resumes after any seizures that they do have. So, talking about seizures, once again, can result from a high fever or from disorders such as epilepsy. They can vary in intensity. During the seizure, child might lose consciousness, eyes roll back in their head, teeth become clenched, body shakes with jerky movements, skin can turn blue. Sometimes the child might lose their bladder and bowel control. For these patients, we need to place them on the floor or on a bed to prevent any further injury, move anything away from them so they don't harm themselves. Maintain an adequate airway after the seizure ends. Make sure their respirations are good. Provide supplemental oxygen. Arrange for prompt transport. Monitor those vital signs and support the ABCs. And if they are running a fever and we believe that's what's causing the seizure, we need to try and cool that patient. Those seizures that are caused by high fevers usually only last about 20 seconds. So we need to be prepared for treating them after they come out of the seizure. Vomiting and diarrhea. If you have kids, you know that this happens quite often as well. It's usually caused by gastrointestinal infections. They can produce severe dehydration. Dehydrated child will be lethargic, has very dry skin. If they're very severely dehydrated, they might have to be hospitalized. If we suspect dehydration, we need to arrange for transport. We need to get these guys to the hospital and get them taken care of. One of our most serious causes of abdominal pain in children is appendicitis. It's going to be seen in people between 10 and 25 years of age. Usually the child is nauseated, has no appetite, and occasionally will vomit. We need to treat every child with a sore, tender abdomen as an emergency. We need to arrange for prompt transport. Those pains usually start as a cramping. Near the belly button area, might move to the lower right quadrant, become steady and more severe. Like I said, they might be nauseated, no appetite, occasionally vomit. Poisonings, because children have a tendency to stick stuff in their mouths, they can get into poison. Remember that an ingested poison is taken by mouth. Some of the signs and symptoms of poisoning might be chemical burns, odors, stains around the mouth, nausea, vomiting, abdominal pain, and diarrhea. Some later signs would be abnormal decreased respirations, unconsciousness, seizures. If we can, we want to try and identify the poison, send the container to the emergency department, gather any spilled tablets and replace them in the bottle so they can be counted. We're going to contact the local poison control center. If transportation is delayed, we should probably contact them even if transport is not delayed. Let's find out what we need to do for these guys. You may need to give large amounts of water or administer activated charcoal. Remember that that's only if you've been trained. Usual dose for a pediatric patient is between 12.5 to 25 grams. We need to monitor these children's breathing and pulse and arrange for prompt transport. Another type of poisoning is through absorption. This is when the poisonous substance enters through the skin. You'll have localized symptoms, which means it's there, usually there where it was absorbed through the skin, which could include skin irritation or burning. Systemic signs and symptoms include nausea, vomiting, dizziness, and shock. Just like with our adults, we need to ensure that the child is no longer in contact with the poison. If it's dry, we need to brush it off, then wash the child with water for at least 20 minutes. Remember to always protect yourself. Remove any clothing if it is contaminated. Once again, try and identify that poison. Monitor the child for any changes in respiration and pulse. If the child has vomited, save a sample and send it to the hospital. I don't know that I've ever seen that, but okay. Arrange for transport. SIDS, or sudden infant death syndrome, also called crib death. It's a sudden and unexpected death of an apparently healthy infant. Usually occurs in infants between the ages of 3 weeks and 7 months. Right now, there is no adequate scientific explanation for why SIDS happens. We need to be compassionate with the parents. If that infant is still warm, we need to start CPR, continue until help arrives. If the infant is passed, so it's important that if the patient is passed, we don't mistake the large bruise-like blotches that happen on bodies for signs of child abuse. These blotches are caused by the pooling of the infant's blood after death. This also happens in adults. We need to follow our local protocols for the management of deceased patients. So, does that mean we need to get a hold of a sheriff or law enforcement? Maybe you need to call medical examiner. Follow your local protocols. Pediatric trauma. This is going to be the #1 killer of children. We need to treat an injured child as you would treat an injured adult. Remember the following differences: that a child cannot accurately communicate symptoms as well as an adult, and that child might be shy and overwhelmed by adult rescuers. Imagine if you have a child getting hit by a car, there's going to be a lot of people there. There's going to be parents, law enforcement, fire department, EMS. All these people are going to be all over this patient, and they're going to be very overwhelmed by everything that's going on. So we need to remember that. Try and get them calmed down. So as we said, we need to treat them as we would treat an adult. May need to adapt materials and equipment to the child's size. So can we use a KED on a child? Probably not. Can we adjust stuff to make the same thing? Yes. They do make pediatric backboards. We need to have some pediatric splints, stuff like that. The other thing to remember is that a child does not show signs of shock as early as an adult. But once they do, it is going to progress to severe shock very quickly. Children are able to compensate very adequately for a long time, and then they just go off the edge, and now we have a major problem. So it's important that we learn patterns of injury. They'll be related to 3 factors: the type of trauma they experience, the type of activity causing the injury, and child's anatomy. By learning some of these patterns, we can anticipate the injuries that we might find when we examine them. No matter what the cause of injury, we need to remember to treat ABCs first. Well, life threats first, and then ABCs. We need to do a full body assessment and hands-on. We need to remember the full body assessment is a hands-on procedure, and a complete examination is especially important because, like I said earlier, child cannot always communicate symptoms that they might be having. With motor vehicle crashes, unrestrained patients have more head and neck injuries. This is going into patterns of injury. So they might have more head and neck injuries. Restrained patients often suffer head, spinal, and abdominal injuries because think about where those belts are sitting. With bicycle accidents, children often suffer head, spinal, abdominal, and extremity injuries. Hopefully they're wearing their helmet because this can greatly reduce the number and severity of head injuries. When children are hit by cars, they're going to often sustain chest, abdominal, thigh, and extremity injuries. If you think about how tall a child is compared to the front of a car, all that torso is right there at the very front of the car. Falls from height or diving accidents can cause head, spinal, and extremity injuries. Burns are another major cause of injuries in children. So, sports injuries can cause a wide variety of injuries depending on the type of sport activity. Regardless of the injury, we need to check the patient's ABCs, stop severe bleeding, treat for shock, do that full body assessment, stabilize any injuries we find. If we have any head lacerations, we need to treat those wounds with direct pressure and bandaging. So our children, like I've said it a few times already, they're going to show shock symptoms much more slowly than adults, but they're going to progress. Once they do start showing, they're going to progress through the stages of shock very quickly. If signs of shock are present, the child is already in severe shock. So that cool, clammy skin, rapid, weak pulse, rapid or shallow respirations. It's common for children who sustain head injuries to have seizures. The greatest dangers are airway obstruction and hemorrhage. Treatment is going to be open the airway, control the bleeding, and arrange for prompt transport. Car seats in children. So if we find a child properly restrained in a car seat after a motor vehicle crash, we can leave the child in that seat until the ambulance arrives. It's supporting their back. It's helping them, keep from moving around. We do need to hold their head to maintain C-spine because they'll be whipping their head about if they're really hurt. In many cases, we might transport a child to the hospital secured in that car seat. Car seats are made for this, as long as they are properly restrained. That's the thing we need to remember here, is that they need to be properly restrained. So some things we might see: child abuse. We need to be concerned if the child is withdrawn, fearful, hostile, unwilling to discuss how the injuries occurred. We need to treat the child's injuries, and if we suspect abuse, we need to ensure the child's safety. So a good indication of child abuse is when the child's injuries don't match the story you're being told about how they occurred. We need to make sure to ensure that safety of the child. If the child gets transported to a medical facility, we need to inform, somebody there. If the parents object to having the child transported, or they object to having the child examined by a physician, we need to get law enforcement out there. Okay, we need to explain our concerns. Remember, child safety is our foremost concern with these. So in child abuse, some signs and symptoms would be multiple fractures, bruises in various stages of healing, human bites, burns, reports of bizarre accidents. Children are abused all the time, and we got to keep an eye out for them and make sure that they're taken care of. We need to get them out of these situations. We don't need to be getting into the parents' face. We don't need to be accusing them of anything. We need to get law enforcement involved so that it can be done properly. If we start accusing the parents of stuff, that's a good way of putting ourselves in danger. And then we're involved in something and we're not getting the child taken care of. So we need to remember that. The pictures on these pages, you can see the multiple bruises in various stages of healing. The hand in the middle is supposed to be human bite marks, I guess. And then the one on the right is going to be what's called stalking burns. This occurs when people, you can also see it on the hands. People will get boiling water and stick their children's feet and or hands into it. So these are things that we need to be watching out for, making sure these kiddos are taken care of. We need to get the child transported. Like I said, if the parents object, we're going to summon law enforcement. Something else we need to be on the lookout for is signs and symptoms of neglect. This is going to be young children without any adult supervision, malnourished children, unsafe living environment, untreated chronic illnesses. So you got that kid with asthma and nobody's getting it treated, or they got the flu or something like that. If they're not getting these things kind of taken care of, we need to know that those are signs of neglect. Sexual assault in children. So in addition to experiencing sexual assault, the child might have been beaten and have other serious injuries. We need to obtain as much information from the child and any witnesses, provide our caring approach. We need to get these children transported to an appropriate medical facility as soon as possible. Remember not to have them change their clothes, remove any diapers. They need to get transported where somebody can do it's like a rape assessment kit that they do at the hospital, but they'll be able to collect samples. So just keep them in their clothes, get them transported immediately. So, emergency medical responder debriefing. Like we talked about at the very beginning of this chapter, these calls involving children tend to produce strong emotional reactions. You might have noticed that talking about child abuse and sexual assaults in children wasn't something that I really want to talk about. These are things that, like it says, cause strong emotional reactions. You might need to talk about your feelings of anger, frustration with a counselor, co-workers, somebody like that. By attending briefing sessions, you can express your feelings, you can learn some coping strategies, and maintain a healthy approach to future calls. So in summary, because of the anatomy of children and infants differ from that of adults, special knowledge and skills are needed to assess and treat pediatric patients. Remember that we're treating both the child and the parent because they both might be frightened and anxious. So you have to be calm, controlled, professional. Child who is unresponsive, is lackluster, appears ill, should be evaluated carefully because lack of activity and interest signals serious illness or injury. Remember, our three components of pediatric assessment triangle are overall appearance, work of breathing, and circulation of the skin. It's important to maintain the patient's airway, ventilate adequately. Any child with respiratory problems. Young children often obstruct their upper and lower airways with foreign objects such as small toys, candy, stuff like that. In complete or severe airway obstruction in the conscious child, we should perform the Heimlich maneuver. And if they become unresponsive, we're going to start CPR. To relieve an airway obstruction in an infant, use a combination of back slaps and chest thrusts. Our three serious respiratory problems in pediatric patients are asthma, croup, and epiglottitis. Other emergencies include drowning, heat-related illnesses, high fevers, seizures, vomiting, diarrhea, abdominal pain. Two most common types of poisoning are going to be ingestion by mouth and absorption, which is through the skin. Remember, SIDS is also called crib death, is unexpected death of an apparently healthy infant. We're going to have to help treat the parents with this one, as well as performing CPR if we have a viable patient. Major trauma in children usually results in multiple systems injuries. If you suspect child abuse or sexual assault, you must transport the child to an appropriate facility or get law enforcement involved. Quick review. So the purpose of the pediatric assessment triangle is to Guide the hands-on physical assessment, help you determine the child's vital signs are appropriate, allow you to quickly form a general impression, or help you remember the systematic assessment process. So our systematic assessment process is done on all patients. We should know vital signs for all our age groups. Our primary assessment and our chief complaint is going to guide us for our hands-on physical assessment. So remember that our pediatric assessment triangle is helping us quickly form a general impression of the child, and this should be able to be performed from across the room. We don't even have to be right in front of the patient. We should be able to just look at them and listen to them and know what's going on. All right. Which of the following statements about SIDS is false? Usually occurs in children between the ages of 3 and 7. There's no adequate scientific explanation. It occurs in apparently healthy children. We should start CPR if the child is still warm when we arrive. So we're looking for something that's false. So we know that if the child's still warm when we arrive, we need to start CPR. It does occur in apparently healthy children, and there is no scientific explanation. So the one that's false is A, usually occurs in children between the ages of 3 and 7. Remember that it usually occurs in children between the ages of 3 weeks and 7 months. Okay. Which of the following is not common respiratory condition in children? We have asthma, epiglottitis, pneumonia, and croup. Well, our 3 big ones that we talked about were asthma, epiglottitis, and croup. So our one that's not common in children is going to be pneumonia. All right, guys, this was the end of Chapter 17. We'll be getting on to Chapter 18. We'll see you next time.